Okay, so we're going to begin talking about neuro with neuro assessment, and then we're going to break down a lot of different neurologic disorders that are more likely to occur in children and young adults. So first of all, as with any assessment, we begin with history, and we want to know about family history of any kind of neurologic problems. That's going to be brain, spinal cord, or nerve issues. We're going to ask about the individual's health history. There are some systemic disorders that may contribute to neurologic issues. There also are symptoms or conditions that may trigger us to think, hey, this may be a neurologic issue. We want to take a history of the current injury or illness. Infants and small children we need to assess based on their developmental norms. So when we are performing a neuro assessment on an adult, we look at orientation, for example. Well, an infant can't follow instructions. They can't have a best verbal response. So remember that we're assessing them based on where they should be developmentally. Vital signs are an important part of neurologic assessment. There are particular types of neurologic injury that affect heart and respiratory rates, depth, heart rhythm, and there are effects on blood pressure. So vital signs are important. We'll look at trends for vital signs. Also, there are neurologic issues that can affect temperature. So that beginning then leads into a neuro assessment, or a more focused neuro assessment. We want to assess that patient's level of consciousness and orientation first. So when I enter the room, I'm going to be talking to the patient as I go. And depending on that patient's responses, I may escalate that stimulus to try to get a response. So as I enter the room, I'm going to begin to try to converse with that patient, and I want to see what their response is to speech. And if I don't get response to speech, I might try to speak up a little louder. Maybe they have poor hearing. I might go see if I can like shake them and see if maybe they were sleeping. But I'm going to progressively increase that stimulus to see what the patient's response is. And we're going to talk about those levels of consciousness in just a minute, but I want to show you the Glasgow Coma Scale. Okay. And it's in your notes. You can find it all over the internet. But let's look at this one that's in your notes. I'm going to have to increase the size so that you can see it better. Okay. So if I walk into the room, Glasgow Coma Scale is a quick assessment of level of consciousness and responsiveness. It is not a full neuro assessment, but it is part of every neuro assessment. And in particular, it gives us a quick look at that patient's level of consciousness in an emergency situation. And we look at trends and whether those trends, whether there's a change over time. So the patient is ranked based on 3 responses: their eye-opening response, their best verbal response, and their best motor response. Okay. So for eye-opening, if that patient opens their eyes spontaneously, they get 4 points. If they open to speech, they get 3 points. If it takes pain to get them to open their eyes, it's 2 points. If there's no response, they don't open their eyes no matter what you do, they get 1 point. Okay. For best verbal response, if that patient is oriented to time, place, and person, they get 5 points. If they are confused, meaning they are disoriented to any of those, but their words make sense, they get 4 points. If they say words that are inappropriate, like the words that not not curse words, not bad language. I'm talking about if they say words that are not appropriate to the situation. And that would be, say, I ask, how are you doing this morning? Can you tell me where you are? And the person says orange. That would be inappropriate words. They're using actual words, but they're not appropriate in response to the questions that are being asked. That's 3 points. If they make incomprehensible sounds as a response to something that we're doing, they get 2 points. If they don't do that, they get 1 point. Okay. Now, their best motor response, do they obey commands? I say, can you do this? That's 6 points. Localizing pain is 5 points. So if I try to talk to the person, I'm not getting, they can't obey commands, they're not responding, I can't get them to do something I ask them to do, then I would apply a pain stimulus. We're going to talk about that in a minute. And if they try to localize it, then that's 5 points. Localize means they're trying to reach for and push away that pain stimulus. Flexion, withdrawal from pain. So if they don't try to push it away, then do they pull away from it? Okay, they pull away from what hurts. That's 4 points. Now, there are 2 types of abnormal movements called posturing. On the Glasgow Coma Scale, they're listed as abnormal flexion and abnormal extension. You will see the term posturing, and that's what it's talking about. So decorticate posturing or abnormal flexion is when a stimulus, a pain stimulus or other stimulus is applied. The best response they give is posturing. They pull all of their limbs inward in flexion. Okay. Now, abnormal extension or decerebrate posturing, everything is pushed out. We're going to try to get far enough back you can see this. You'll see legs extended, toes pointed, arms extended, and I'm moving my arms upward so you can see the hands are rotated. Okay, that's posturing. That's going to usually be down by their side. So that is 2 points. No motor response is 1 point. So lowest Glasgow Coma Scale is 3. That patient is totally unresponsive. 8 points or less are considered comatose. Best response is 15. 14 is seen pretty commonly. We have patients who either were asleep, so they don't get 4 points for opening their eyes spontaneously because we have to wake them up. Technically, that's going to be 14 points, even if they would be able to open their eyes spontaneously otherwise. But we see a lot of, the more often one we see is that patient is disoriented. Everything else is fine. They're alert, but they're not oriented, and they're going to lose a point for best verbal response. So I know you heard me talk about that pain response or that pain stimulus. I want to talk just a minute about what that looks like. Okay, so I talked about applying a pain stimulus. Now, what this assessment looks like when you perform this assessment, you enter the room and you speak to your patient. Hello, Mr. Johnson, how are you doing today? Mr. Johnson responds to you verbally, then you can mark something about their verbal response. Mr. Johnson's eyes open. If they're already open, that's 4. Or if you observe him and he's opened his eyes and looked around, that would be 4. If you have to talk to him to get his eyes open, it's 3. Okay. Typically, when you go in and wake a patient up, you want to give them a little bit of time to respond so that you can give them that full score. But if your patient's awake, their eyes are already open, that's going to be spontaneous. But if they open when you talk to them, that's 3. And then you're going to ask, so Mr. Johnson, how are you doing today? Can you tell me where you are? Can you tell me your full name? Can you tell me something about time? Now, this gets tricky. If we ask a patient about time in the hospital, if we ask what day it is, that can really easily get mixed up. Okay. If we ask what year it is, they might have that might give us a better picture of their orientation. A question we used to ask a lot is, who's the president? And a lot of people have dropped that from their questions just because of sometimes that can cause some political agitation because of the last few years of unrest. So we want to ask, what year is it? What's the season? What's the next holiday? Something that's going to let us know they have some idea what's going on in terms of time. So if they're oriented times 3, they get all the points for that, right? And then we're going to ask them, can you do something? Now, when you're asking your patient to obey commands, please don't put your fingers in their hand and say, can you squeeze my hand? Because that is a reflex. And that patient who may not be able to follow commands might still squeeze your hand because that reflex might be intact. So if we have a patient who's not responding as much to speech, and we're trying to see, can they obey commands, or they're unable to speak for some reason, we want to ask them to lift a finger or something along those lines, something that's going to be really clear. Okay, so what if they don't respond when we go in and talk to them? Well, then you want to go in and try to wake them up, try to gently touch them, maybe get a little bit more vigorous, shake their shoulder. You can't get them to wake up with that. You can't get a response. You want to really make sure that you're giving them a chance to wake up to that pain, because if someone's a heavy sleeper and you walk in and just kind of barely touch them, and then you move to pain, they may wake up swinging. So you want to really make sure that you've made a good effort to wake them up and see, are they oriented? Do they know what's going on? Are they able to follow commands? If not, if they don't wake up to touch, then you move to pain. Now, there are safe and unsafe ways to apply pain stimulus. The most common way that you hear about is a sternal rub. I am not a fan of a sternal rub. When I was a neuro nurse many years ago, I was taught not to do sternal rub for a couple of reasons. If they've had a heart procedure, number one, if the sternum was affected, you don't want to put any pressure. You don't want to put heavy pressure on that. Another, though, is that in rare cases, a really vigorous sternal rub with too much pressure could trigger some arrhythmia. So I was taught not to do that. I was taught a few different ways. One, you can do nail bed pressure. Okay, if I take a pin, put it across that person's nail bed and press it, it does not take a lot of pressure to cause enough pain to get a reaction from that patient. Okay, it's not going to do permanent damage. The only damage that's going to be done is maybe a bruise, right? So nail bed pressure. Another is a trapezius squeeze. You get the trapezius muscle in between 2 fingers and squeeze. Again, it doesn't take a lot of strength. It doesn't take a lot of pressure. You get pain. You're very unlikely to actually cause any kind of damage. So those are my favorites. I have also seen, I have to tell you about one I've seen or heard of. I haven't seen it used, but I've heard of people using it. That's absolutely inappropriate. Both because it's just inappropriate touching, but also because it can cause damage, and that's nipple twisting. So if you ever see or hear that, that's not an appropriate way to apply pain. So let's say that I'm using the trapezius squeeze. I've gone in, Mr. Johnson, how are you doing this morning? Mr. Johnson doesn't respond. I get a little bit louder, maybe touch Mr. Johnson's shoulder. How are you doing this morning? Still no response. I maybe shake his shoulder to make sure I just can't get, it's not that he's just a really deep sleeper. No response. So then I decide I'm going to try applying a pain stimulus. The same using the trapezius squeeze. I'm looking at, does he make any verbal response, or does he open his eyes to that? And does he have any motor response? So if he opens his eyes to pain, that's 2 points. Okay. If he pulls away when I squeeze it, that trapezius muscle, that's withdrawal from that pain. Now, what if he tries to reach for my hand and push it away? Okay, that's localizing pain. So do you see how we use that escalating stimulus to get a Glasgow Coma Scale? Now, the other thing we can get from that is level of consciousness. If your patient is fully conscious, they are alert, okay? Now, you can be alert and oriented, or you can be alert and disoriented. Alertness is about, are they fully conscious and responsive? Someone can be alert and still not know what day it is or where they are, okay? Confusion is impaired decision making. Okay, your patient's trying to eat their socks, that's poor decision making, or on a milder level, maybe they are making poor decisions in their daily life. Think of a patient with dementia who is maybe forgetting to eat, or maybe deciding that they only need to eat one food item, things like that. So confusion is impaired decision making. Disorientation is when the patient is confused regarding time, place, or person. And we would say patient-oriented times 1, disoriented 2, place and time, or something along those lines. We want to be clear about what they're oriented and disoriented to. So if you say oriented times 3, you're saying your patient knows who they are, where they are, and when they are. Lethargy, that patient has limited spontaneous movement, they have sluggish speech, and they're drowsy, but they are responding. So think of a patient that's very sedated. Also, you may see lethargy, just that kind of draggy, limited response. They're responding, but they're just not moving a lot. Their speech is very slow, maybe slurred. That can be a sign of neurologic injury as well. Obtunded is when that patient is arousable only with stimulation. So how many of you have gone into your patient's room and you try to wake them up? Can't wake them up. So you try a little bit more, and maybe when you shake their shoulder, they wake up and talk to you. But as soon as you stop that really vigorous stimulation, they're back out. Okay, that's obtundation. Stupor, that patient responds slowly and they may moan to vigorous stimulation, but not any actual words. Coma, the patient has no motor or verbal response, or they have extension posturing to a noxious stimulus. A persistent vegetative state, this is not something that nursing diagnoses, but you may care for patients in a persistent vegetative state. There's also been controversy about the diagnostic criteria for this, but this means that they have permanent loss of cerebral cortex function. Their eyes follow objects by reflex. They follow the direction of sound. Their limbs may withdraw from stimulus. They may have a reflex grasp. They may grimace. They may swallow. They may groan or cry, but they don't have words. So that's going to be persistent vegetative state. And this is after the initial injury, we're talking about maybe the function that someone is left with. Okay, so lots and lots of time on orientation, level of consciousness, coma scale, right? Now we're going to talk about eyes. You always assess pupils. PERLA is pupils equal, round, reactive to light, and accommodate. If you have pupil changes, you need to first assess, is this baseline for this patient? Because if it's a new pupil change, that is potentially neurologic injury. Pinpoint pupils may happen because of opiates or barbiturates. So your patients just had surgery and they were on opiate pain medicine. Their pupils may be very tiny. It can also happen because of brainstem dysfunction. So if their pupils are constricted, pinpoint, and we don't know, there's not a medication reason for it, that's something to document, something to report. We always document that, something to report. A dilated pupil that's reactive, so it's very dilated, but when you put light in it, it reacts. That can be from a seizure or from eye trauma. A fixed dilated pupil, that means that pupil is dilated, and when you put light in it, it doesn't react, is usually paralysis of cranial nerve 3. That is often from herniation, when part of the brain tissue gets shoved into a space where it doesn't belong by pressure. If it's only one side, that suggests that there is a lesion on one side. If the pupils are fixed and dilated for more than 5 minutes, it's likely that the brainstem's damaged. But you may also see pupils fixed and dilated with hypothermia, anoxia, ischemia, atropine poisoning, or if they've had drops to dilate. So when you go to the eye doctor, they dilate your eyes to look. Okay. And some other assessments involving eyes that we might do: the doll's head maneuver. The head is rotated quickly to one side and then to the other. The eyes should move to the opposite side together. So move the patient's head quickly this way and then this way. Their eyes should move together to the opposite side where they're being turned, right? If not, they may have brainstem damage or cranial nerve 3. The oculovestibular response. So this is not done on a patient who is alert or we can get another response from. But if a patient is comatose, the oculovestibular response may be done. The head of bed's elevated to 30 degrees, and then the auditory canal is irrigated with 10 milliliters of ice water. That's going to be painful, so we're not doing this to a patient who just for funsies. We're not doing this to someone that we get other responses from. The eyes should move together to the side of the stimulation. If not, they may have impairment of the pons. And remember, the pons helps regulate respiratory rate and depth. They also, a provider may use an ophthalmoscope to look for bleeding and edema in the deeper structures of the eye. Okay, we're going to stop there and come back and talk about further diagnosis, because this has gotten kind of lengthy and I don't want these to get too long.